Welcome back to the Ketotic Hypoglycemia International Conference, where Dr. Terry Dirks has just presented about monitoring ketotic hypoglycemia and treating ketotic hypoglycemia. We have now prepared a live Q&A, not only with Dr. Terry Dirks, but with a lot of the members of the Scientific Advisory Board. So we will just say welcome very soon to our experts. Hello, Terry.
Hello, good afternoon.
Good afternoon, and hello, Paul.
Good morning from the US.
Good morning, and good morning to Pratik.
Good afternoon.
Good afternoon to Pratik. And hi to Henrik.
Good afternoon.
Okay, hi. Great, we have a lot of questions, and this section is very, very important. So that is why I have invited you all to join. So I have a question from the audience. When should we consider a feeding tube? We feel like it's a very big procedure because the doctors state that our child will grow out of it. Our child struggles with eating aversions. So who would like to take that? Henrik?
It's very individualized when you have to install a feeding tube. We did that when we saw that a dietary plan with cornstarch and complex carbohydrates were not enough in the most severely affected children. But we realized that glyphosate, we call it super cornstarch, is a product that actually has some of the same effects as continuous feeding with maltose that was our other choice. And when glyphosate was allowed below all down to 2 years, then we had the chance to use that, and that has in many cases been enough. The problem with glyphosate is that it is not easy to drink, and if you have a G tube, it's much more easy to give it. So it can also be necessary to have a G tube for emergency reasons. If energy gel and quick sugar drinks are not enough. So there are many both preventive and acute therapy reasons to have a G tube, and it's an individual judgment in every case.
Thank you, Henrik. Anyone else wants to add on that? Paul?
Yes, I would agree completely with Henrik, and it's very important for everyone out here to remember that the key to treating a condition when we don't know the exact etiology or the cause that everyone has is that each individual family has their own precision type of care. In other words, that we trying to determine for each individual family and child what is the best thing that we need to do. So my general rule of thumb is that if I'm unable to prevent hospitalizations once we've made a diagnosis, and if the patient continues to have hospitalizations or has extremely short fasting durations where they become ketotic within 4 to 6 hours, then they're the two reasons why I would recommend strongly a G button. And then obviously for families whose children can't fast overnight and need middle of the night feeding, that would be another recommendation to put a G button in. But again, what's important is that each family talk with their doctor, understand what the limitations of what they can do at home with oral feeding is, and if you're unable to prevent hospitalization, strongly consider a G button. And although it is a procedure to put it in, it's a relatively simple and safe procedure. And at the end of the day, when you don't need the G button anymore, it's a very simple procedure to remove it. So I believe the net benefits outweigh the risk in many families, but not necessarily all.
Thank you so much. I'm just typing to get David into the Q&A, but I will just hear if anyone else has anything to say. Although, yeah, Pratik.
Yeah, so I completely agree as well. And just kind of experience point of view, what we kind of see, and it depends on where obviously you have in terms of your local care. So obviously, it's very important from each country, and has got different ways of managing in terms of what support they have in the community. But what we generally would do here in the UK is that obviously if the child is needing overnight continuous NG feeds, then it's not safe. So obviously it depends on the fasting tolerance, and if they're needing frequent bolus feeds, overnight NG feeds, then sometimes we have to consider putting it G button. So having a NG tube has got its own kind of implications as well. So if we think that children are requiring more feeds overnight, or continuous feeds, or requiring bolus feeds, then we have to then think about moving into G button. But also it depends on the individual child as what exactly the
Thank
cause
you.
is.
Thank you so much, Pratik. And we just welcome Sir David Weinstein. Thank you for joining us.
Good morning, good afternoon, everybody.
We were just talking about G tubes and
I've
how
been
they.
on there. I've been hearing about it.
Okay.
The one thing I would just add, you mentioned the glyphosate earlier, and
Yes.
they did come out with a flavored glyphosate, which is much better. And if people haven't tried it and they're using glyphosate, it's worth doing.
Great. From a personal perspective, I hope it tastes better with lemon than without. I'm taking glyphosate too. So great. So, and I will move on with the next question. We are told that my child will grow out of ketotic hypoglycemia. He's now 12. Can my child still outgrow ketotic hypoglycemia? Yes. And David?
So most of the people who are involved with this organization have pathological ketotic hypoglycemia, meaning that there's probably a metabolic origin to it, whether it's glycogen storage disease, mitochondrial disorders, or some of the disorders we heard about yesterday. Those people will not ever outgrow it. It will get milder as people get older. Some people can get so mild that they don't need ongoing treatment, but any period of stress can bring it out. So fasting should always be avoided. And if someone gets sick, it can bring it out. I will also say there are periods where it is more likely to come out, and that is during puberty because of the increased demands. During pregnancy, when a mother who had it as a youngster gets pregnant, it may come out again. So these are periods where it should be monitored.
Thank you so much. Anyone else want to add on that? Otherwise, I will move forward to the next question. So, this is from Erica from the US. She's asking, is it normal for children to have ketones in their blood every day and all day? And what level do they start to affect our children? So this, I think, might be, yes, Henrik?
This is not normal. Ketones should be low, below 0.5 or 0.6, and only very unusually gets higher than 1.0. So if you have everyday ketones, either you're undertreated with ketotic hypoglycemia, or you have a specific problem with the ketone transport or metabolism.
Thank you so much, Henrik. Anyone else have another view? Otherwise, I will move forward to Monica. Oh, sorry,
Tanya?
Terry?
Terry.
I think in my presentation, I also showed that for, let's say, normal children, ketones after a regular overnight fast are abnormal. So that's the answer. For
Yes.
patients with ketotic hypoglycemia, the individual patients will define what is normal for him or for her, and that may be different from these numbers. Sometimes it is very difficult to completely abolish any ketones. That probably also depends on the severity. And then really you need more measures with the diet, and sometimes the G tube is needed. also because children do not always tolerate the dietary measures that we prescribe. For some children, after 1.5 years or 2 years, when they have to start with cornstarch, they simply don't accept this, as much as we would like them to accept it. So then the numbers in correlation with the symptoms and signs would define how strict you would be, whether you would start with the G-tube or not, and what levels of ketones or glucose under normal conditions you would accept. So here I think we have to echo every time again, this is really an individualized approach. And one of the things that is lacking here, I think, is the lack of natural history
Oh,
data.
sorry. That's my hypo. Søren, vil du give mig et eller andet speed? Sorry.
No? Safety
Sorry.
measures first. Huh?
Yes. Sorry. Just continue. I'm just taking something to eat.
Okay. So I think that these individual measures, what families can discuss together with their doctors, are very important. And up to now, it is difficult, I find, to generalize the rules that we have learned in other fields, such as hyperinsulinism or the glycogen storage disease or the fatty acid oxidation disorders.
Thank you. Thank you. And then I have some questions from the audience. Again, I will just follow up. Okay. This is from Melissa. She asked, how do we get physicians to explore why our children have ketotic hypoglycemia versus just brushing it off as they will grow out of it? Yes, that's a very difficult question to answer. Henrik.
We have to communicate. We have to communicate in the public field and scientific.
Yes. Anyone else?
Yes, I was going to add that, there are guidelines on the management and diagnosis of hypoglycemia, and we need to continue to push those guidelines, because those guidelines do not recommend that people brush off diseases. They recommend that you find the cause of the condition and that you implement a, therapy that's appropriate for the family. So there are guidelines out there, and I think if you asked every one of your experts to raise their hand as to how many people have given at least 10 talks about helping other doctors recognize hypoglycemia, we'd all be raising our hands. So we're doing our bit. And, the thing about the family organizations are that they can help too by getting the word out. You family members can help by downloading copies of these papers and sending them to your doctors. You can send them summaries of your stories and say, hey, especially when you get a diagnosis after years of no diagnosis, go back and tell all the doctors that you met. So we have to make people understand that this is a real and serious condition.
Thank you so much, Paul. Okay, I have a question more. And I don't know if you can answer, but I'm asking it. This is from Elena, and we will hear her story later on today. But she's asking, are consistently high morning ketones usually a sign of missed hypoglycemic events? Or are there other common explanations in a younger child with a normal to high carb diet? So now we are talking about the high ketones. Why are they there? And I see a lot of parents describing a normal blood sugar and high ketones. So who will take that? Terry.
This would either mean that there is increased fatty acid oxidation, or there is a decrease of the clearance of the ketones. And the MCT1 transporter is mentioned as a possibility of the latter yesterday already. But the fatty acid oxidation means that patients are burning their energy sources, so fat as an energy source. And the usual sequence, as I demonstrated in my presentation, would be to start with starches, and then by protein, and then by fat. So as soon as you start the phase of fatty acid oxidation, the muscle breakdown is already taking place. Not in
Thank
all
you.
not in all situations the ketosis is after the development of the hypoglycemia. So also for glycogen storage diseases, we have demonstrated that some patients do not necessarily have to develop hypoglycemia before hyperketosis occurs. So it is a warning sign.
Okay.
That's how I would
Henrik.
read it.
I like to add that the blood glucose does not necessarily has to be low before ketones get high. When blood glucose goes below 70 in some patients, they start to produce ketones, and that's 4.0, 3.9 millimoles per liter. So either there has been missed hypoglycemia or a very quick start of ketone production.
Thank you so much. And David?
I would just encourage everybody to watch Dr. Parmar's upcoming talk on which will address the overnight ketone formation. But it is not normal, and it's a sign, as everybody else has said, it's a sign of pathology.
Thank you so much, David. And I will move forward with a question often asked. What is recommended to give my child when they are having a low blood sugar to raise it quickly? And how do I keep it up to avoid rebound hypoglycemia? Terry, maybe?
I think it depends on the situation. If it is, for instance, during exercise, and children are well, they don't have fever, they are not vomiting, this is a completely different situation than when patients have a fever and they start to vomit and have a hypoglycemia under these circumstances. So for the first situation, I think the prevention is key. If you have a good dietary plan, and if you have shown to develop hypoglycemias very quickly, some children do need cornstarch also during the day. In some cases, extra protein may help. And if, for instance, during exercise, you take these measures, you should be able to prevent hypoglycemias. Something different is when children are sick. And the treatment there is completely different, I would say. And that also relates to a question. I'm not taking over your job, Daniela, but there's a very nice question by Lauren, because she was asking, when do you have to go to the hospital for IV glucose? And that relates to this question too. You would like to prevent hypoglycemias to occur during intercurrent illness. And ideally, you would start with an emergency regimen already the first time after children are vomiting, before hypoglycemias can occur, ideally. And that's the reason why we have emergency letters that are individualized. And we have in our practice the habit to call the local pediatricians for every patient, just to ensure that we are all on the same page, that they accept our emergency regimens, because this usually takes place during the nights, in the weekends, when the doctor who knows the families the best is on holidays. So all these circumstances that you would like to prevent. And you can only, manage these expectations in advance by reaching out to these doctors. And, then very practically, I find, for instance, maltodextrin solutions very helpful for that, because they have as fast carbohydrates that could cause an increase of glucose very rapidly, but they carry the risk in the same time of a rebound hypoglycemia. Then, ideally, you would like either a continuous administration of these fast carbohydrates or a combination of maltodextrin with a slowly digestible carbohydrate source, such as a starch. But children with a gastroenteritis do not tolerate these starch very easily. So really, vomiting is the time to start thinking ahead. And you should have discussed these scenarios already in advance with your doctor.
Thank you so much, Terry. Anyone else? No? And if I just want to say to you all of you experts, if you see an amazing question you feel like you have to answer in the chat, then just raise your hands, because I know that you're following very closely. But I will just move forward with another question, because it's amazing to have you all united here today, and we have a lot of questions. So the next question. This is from Cheryl. Why does my son need more support the day after a sport? Ketones show up only afterwards, even with extra cornstarch and protein. So, anyone? David?
I'll take it. When someone does sports, muscles use glycogen, and even if they have the liver form of one of the metabolic disorders that we're talking about, because the muscles use glycogen, it has to replenish its stores. And so it's very common for the blood sugars to fall for 4 to 6 hours after sports if there hasn't been a good meal. So this is particularly a problem in the evening, and with sports like swimming, which really do drop the blood glucose level. So it's very important that after sports to make sure that there's a good snack, especially something with protein is also important.
Thank you, David. And here is a question that has been raised a lot of time in the support group. Are there any downside to treatment with cornstarch and continuous feeds? I'm afraid of the long-term effect of my child. Yes. I don't know if there has been any studies on this, but anyone?
While I was in practice, I can say that we had people on cornstarch for 40 years, and we've never seen a significant complication from it, except for the fact that there may be a slightly higher risk of what's called C. diff after antibiotics. And so we recommend probiotics, especially if someone's on antibiotics. But other than that, I think that these treatments are safe.
Thank you. I know that will bring a lot of comfort to our families, David. Thank you. And
Danielle?
Yes.
One of the risks, if doctors or dietitians don't feel comfortable with the use of cornstarch, is when they prescribe too much. So that's the downside. But if you know how much to prescribe, it should be safe. But some people have bad experiences of gastrointestinal complaints, loose stools, in particular after too high doses of cornstarch. That's preventable.
Thank you. And I am just saying a little bit about the management, because I have a question from Mary. She's asking, is there a specific protein supplement that you find most helpful? So do you have any preferences? I think this is maybe Terry. Yes, Terry.
I think that David and I can both comment to that. Part of the answer will be the availability of the products. So not all products are available everywhere, and not all products are reimbursed everywhere. And in my country, for instance, it depends on the insurance companies. So some insurance companies would cover for one product, but not for the other. And that sometimes determines the choice. Even if some children, for instance, complain about the taste or the palatability of a product like ProSource or Protifar, I mean. And that's why ProSource, which is a liquid form, for some children is preferable or more acceptable. But others do not like the flavors of it, and they prefer Protifar. So I think these are the two major determinants.
Thank you so much. And now, David?
David, yeah.
I just want to say there are many good protein sources. I would caution people to avoid protein products that are being marketed for athletes and weightlifters, because sometimes they put supplements in those that can be dangerous in these metabolic conditions.
Thank you for that warning, David. I will move on with a question from Kitty from the Faroe Islands. She's asking, would you expert recommend to hold the blood sugar under the limit where the insulin production will be activated to have more stable blood glucose? I don't know if anyone can answer that. Henrik?
I give it a try. Usually, there's no issue with insulin production in ketotic hypoglycemia. It's a normal balance there. But of course, there may be a few exceptions, but usually it's a normal balance. If sugar goes up, insulin goes up, and then it will regulate the glucose down to normal level. So you cannot really try to balance like a glucose level between 4 to 5. That I think that's not needed for most patients with ketotic hypoglycemia. But if you have a diagnosed problem with hyperinsulinism after a protein load or a glucose load, then you should consider to be more strict. But that should only be after a diagnosis. What Terry stressed, that over and under treatment are both important problems. You should not aim to overtreat, being afraid of insulin.
Now I have a question to Pratik. This is from a family in the UK who used to see you at Great Ormond Street. They asked if you still practice and if they can get a referral to you. They miss you.
Yeah, they. I'm happy to see them. I continue to see children. So if they have anything, they can just send the referral. I've shared my email yesterday, but happy to share the. I'm at Royal London Children's Hospital, so I do see children with hypoglycemia. So if they want to see me, I would be happy to get the referral and email me the referral.
Now to a more general question to all of you. We have questions from the audience who is asking, why are we seeing HI experts, but no one is branding themselves as an IKH expert? Does these experts exist? So, I love the laughing.
Well,
Can you please elaborate? Pratik.
I think we would call ourselves as hypoglycemia experts, or where we obviously it's important that with ketotic hypoglycemia, as you can see, we've got a mix of metabolic experts and endocrine experts, and we kind of see that when we talk about hypoglycemia causes, there are causes, metabolic causes and endocrine causes. So it's not that we are just expert on one condition, but obviously we all work together, and it is something that we would kind of look into causes where we think whether obviously if it's a metabolic cause or underlying endocrine cause. So I guess this KHI has we can see that obviously this is a fantastic conference, which is the first conference, and then I'm hoping that we would say that yes, we are now IKH experts as well. So yeah, but we all look after children with all causes of hypoglycemia.
Thank you.
Danielle, as well, if I could say, depending on what country you're in, but different people look after children and adults with hypoglycemia. So in Europe, it may be more metabolic or more endocrine. And in the United States, it's a mixture. So some of us are endocrine trained and some people are metabolic trained. And some people feel more comfortable just dealing with the hormone things. But as a general rule, if you can find someone who's an expert in one form of hypoglycemia, they'll almost always have a pretty good understanding of the rest, and they'll be willing to tell you if they don't and who you should go see. So that's one good thing about experts is, when we're an expert at very narrow things, and we're very happy to say we don't know enough about something else and send you to the right person. So if you find someone who's interested in some form of hypoglycemia, it's a really good start.
So much, Paul. And now I have the last question. this is a question following up on this. I have a request of a list of IKH doctors or doctors who are understandable about or have knowledge about ketotic hypoglycemia. Is this something KHI is going to work on? And from the KHI side, I can see yes, but I will need the help from the scientific advisory board. So I just need you to, yes, Terry?
I think it is a challenge to make doctors confess what they are good at. We are usually in the position that we publish about topics, and the more you publish, the more people think you are an expert. But for instance, in professional networks such as the European Reference Network for Inherited Metabolic Diseases, you will not find an open information about which centers or which doctors are experts for which diseases. I think it's worthwhile trying, because this is what matters for families, I would say. But the question is then how to define ketotic hypoglycemia. We have noticed also in the last 2 days that there are some differences in interpretation. And in addition to what Hendrik was saying, or to what Pratik was saying, I don't consider myself a hypoglycemia expert, but more a fasting tolerance or fasting intolerance expert, because of these all different biochemical phenomena that may occur. But coming back to how to come up with a list of centers and doctors who know what they are doing, I think this is really something where we have to support the patient organization, and the national patient organization should be able to tell which centers are the centers to go to with your child or adult.
Terry, and with this, we have a lot of work to do in KHI, and we will now move forward to another patient story. Thank you guys for entering this big Q&A.